Exercise 20 deals with respiratory physiology. When you're talking about breathing, we're looking at a couple of different things. That active breathing is called pulmonary ventilation. It's going to be dependent on the atmospheric pressure, which is the pressure that is outside of the body. It's dependent on the intra-alveolar pressure, that's the pressure that's inside the alveoli, and then the intrapleural pressure, which is in the pleural cavity. So all those are going to be interrelated. Couple things to keep in mind is that gas is going to want to go from an area of high pressure to low pressure. It's naturally the way it's going to want it to move. If we talk about negative pressure, it means the pressure is less than what the atmospheric pressure is. If we have positive pressure, it's greater than atmospheric pressure. So you're doing comparisons of something to the atmospheric pressure. Another relationship to keep in mind is that as the volume increases, the pressure is going to decrease. So it's an inverse relationship. As the volume decreases, the pressure would increase. And this is just showing the intraocular pressure, typically kind of where it ranges from. That's inside the lung, the intrapleural pressure, the atmospheric pressure, etc. Just location of where everything is located. What are some of the physical factors that can affect ventilation? Whether the diaphragm is contracting or relaxing, and also your external intercostal muscles, whether they are contracting or relaxing. What's the size of the airways of all from the trachea to the bronchioles, etc. What about pulmonary surfactant? And what about the thoracic cavity? Is it expanding in size, increasing the volume, or decreasing the volume? Because that's going to, as we just said, affect volume affects pressure. So when you are inhaling, inspiration, we're looking at pulmonary ventilation. Inspiration is air flowing into the lungs. What's happening at this point that causes that is that the diaphragm contracts and your external intercostal muscles will contract. As they contract, they are going to increase the thoracic cavity volume. So if you're increasing the thoracic cavity volume, that means you're going to be decreasing the pressure in the lung, in that thoracic cavity area. So the intra-alveoli pressure is going to decrease. If it is less than atmospheric pressure, we said gas wants to go from high pressure to low pressure, so the air is going to flow into the lungs. When you exhale, expiration is a passive process. There's no energy that's required. The air is going to flow out of the lungs. Why does this happen? Because your diaphragm and the external intercostal muscles relax. When they relax, the thoracic cavity volume is going to decrease now. The pressure in the lungs are going to decrease. The lung decreases in size, the volume of the thoracic cavity decreases. So now what happens, that intra-alveoli pressure, that pressure inside the lungs is going to increase. It becomes greater than atmospheric pressure, so the gas is going to flow out of the lungs and you exhale. And this is a diagram that is showing this with both inspiration and expiration. And so what happens when you inhale, once again, the diaphragm contracts. As it contracts, it moves down. The external intercostal muscles, as they contract, if you look at the thoracic cavity, it's moving out and down. So that here the volume is increasing. As volume increases, the pressure decreases. Pressure is greater out here, so it allows the air to flow in. Versus when you exhale, notice here, yes, the diaphragm, as it relaxes, it moves up. So the thoracic cage, which is going to determine what the thoracic cavity volume is like, it's moving up and in. And so therefore now the volume of it has decreased, so pressure increases, and that's going to force the air to flow out. We can take several different respiratory volumes. A respiratory therapist is certainly going to be very familiar with this, monitoring it depending on what the needs of the patient are. Some of the respiratory volumes are things such as tidal volume or TV, average is about 500. This is the amount of air that's inhaled when you're just quietly breathing. The ERV, or expiratory reserve volume, is the amount of air that's forcefully exhaled. Inspiratory reserve volume, IRV, is the amount of air that's forcefully inhaled. And then the residual volume, or RV, is the amount of air remaining in the lungs after you have forcefully exhaled. When you forcefully exhale, you do not completely remove all of the air in the lungs. There's always some air that remains in the lungs to keep those alveoli from collapsing. And that would be your residual volume. There is a small little video that is with this chapter on Blackboard because there's an exercise we often do for the respiratory physiology where you use a spirometer to measure these different volumes. And there is a video that is available on Blackboard showing me using a spirometer and taking these measurements and showing how you do it. I would just say when I did this, I was having some allergy issues, so just be really kind when you look at the numbers. Be nice, because you can definitely tell. For some of the readings, they're low. Some additional measurements, total lung capacity, or TLC. That's when you take all these various lung volumes and add them all together. The VC, or vital capacity, that's the amount of air that's moving in and out of the lungs. So you don't include the residual volume because that always stays in the lungs. So it's just the amount of air moving in and out. Inspiratory capacity, IC, is the maximum amount of air that can be inhaled. And then the FRC is the functional residual capacity. That's the amount of air that remains in the lungs after just a normal expiration, exhaling on there. And so this slide does show these different volumes, what the average amounts are, as you can see on the graph over on the left-hand side. But how you can add these different amounts together. Like I say, someone who's a respiratory therapist, this is what you're going to be dealing with, and measuring these different volumes, comparing, knowing what's normal, what's abnormal. Oftentimes somebody after surgery, you need to monitor this to make sure that the anesthesia is not having a residual effect on it. It can also give you an idea of what their lung capacity is. Is it normal, or is there possibly lung disease, something else that's going on there? The respiratory rate is the number of breaths per minute. This is going to be controlled by your respiratory center in your medulla. Now, a lot of people think, oh, it's controlled by if oxygen levels get low, that's what triggers me to start breathing faster. No, it's actually going to respond more to the concentration of carbon dioxide in the blood. And in lecture, we talk about this quite a bit, but the carbon dioxide and the way that it's transmitted in the blood, carried or transported in the blood with carbonic acid, bicarbonate, and that whole process, it's going to affect the pH. And so your response change of breathing rate is due to the level of carbon dioxide. And that in turn is also related to the pH and trying to keep the pH, that acid-base balance, in check. Normally, a respiration rate under normal conditions should be a nice, rhythmic, consistent rate. Things can increase the rate. Pain, usually a higher temperature is going to increase the rate. If the sympathetic nervous division is activated, that is going to increase the respiration rate as well. So all these factors can play a role in it.